Jeff, I was hoping you could clear up some confusion around the use of medications for cardiovascular disease or just risk. Can you kind of give us an idea of what you are talking to patients about with regards to medication use?
Yeah, so prior to 2013, anyone with high LDL was given a statin, assuming that their LDL was a significant enough risk factor for heart disease that they should be given a statin. Those guidelines were refined in 2013, and the American College of Cardiology said, no, actually, your LDL needs to be above 190 before we give drugs, and we shouldn't just give it to everyone with slightly elevated LDL. We've evolved a lot since 2013. So where we are now is we can much more, accurately predict risk. So what we really want is we want a better risk assessment. Your LDL may be high, but you may be low risk. Your LDL might be low, but you could be high risk. So the best way to identify risk is to actually look in the organ, look in your vasculature and see if you have clinical evidence of disease. So the best way to do that is a coronary calcium score. That test is a good idea for anyone 45 to 70 to properly assess the risk. Best done if somebody has, one or more risk factors. High cholesterol, everybody's been trying to get them on a statin, but their lifestyle is otherwise healthy, they don't think they need one. Or conversely, somebody whose cholesterol might be looking kind of okay, but actually they have additive risk factors for heart disease like sleep apnea, obesity, metabolic disease, maybe they have a high LP, little a, et cetera. So basically there's a lot of markers and risk factors that are floated out there as things that can probably increase your risk. But the best way to actually see if you're at risk is to look under the hood and look at the organ system. So that's come into vogue a lot more in the last 10 years, certainly in our practice in the last 5 or 6 years. So if you do appropriate imaging, you can then move to step 1, which is stratify your risk for heart disease. So do you need a statin or not? Do you need to go on a vegan diet or not? Do you need to worry about heart disease or not? The answer to that question is risk stratification. So we want to see, are you truly at high risk or not? So step 1 is to identify your risk. So if you've had your calcium score and now you find out that you have a little bit of plaque in your arteries, we call that subclinical disease. So now you're identified as somebody who is potentially higher risk because of evidence of subclinical disease, i.e. plaque in your arteries that shouldn't be there. So now what do? Well, first of all, you got to figure out what the drivers were in your unique case. So that's where a precision medical approach comes in. Was it high LP(a)? Was it high LDL? Was it metabolic disease? Was it insulin resistance? Was it obesity? Was it strong family history? Was it genetics? Was it, periodontal disease, et cetera? What were the drivers? Invariably, you can go after LDL, which is still, employed in preventative cardiology. So if you see your cardiologist and you have subclinical disease, i.e. you have some plaque in your arteries at a younger than expected age, appropriately, they're going to want to lower your LDL, 50% or more. And that actually may be the best idea for a lot of patients. It's relatively easy to do. We do that in our clinic using ultra low doses of Crestor and Zetia, which is a great way to lower LDL 50% without side effects. But we're not just focused on LDL, we also try to identify the drivers. So again, now we found you have plaque in your arteries. We need to find out, is it lifestyle, is it genetic? Is it something like a sinister lipid particle that you inherited, like LP(a), periodontal disease, sleep apnea, et cetera? So basically our goal now is we've stratified you as elevated risk. We need to understand the drivers and we need to neutralize as many of these drivers as possible, LDL definitely being one of them. And then we need to monitor you. So we can do monitoring by getting a serial, maybe yearly check at your carotid arteries, looking for plaque regression. 3 to 5 years after your original coronary calcium score, we could repeat another one to see that hopefully we've slowed down the disease process. And then if we haven't, we need to dig deeper and see again, what are the drivers? Hypertension is another driver, for example. So what's not being done well in medicine is proper risk stratification. A lot of clinicians are still only looking at LDL. Serial monitoring using imaging is also something that is not routinely done. And then addressing LDL using low dose of things like Zetia and statins is not routine, but it's well evidenced as a relatively side effect free way in the literature to lower LDL 50%. So there's a lot of options for how to employ preventative cardiology. There's a lot of missed opportunities to properly stratify people's risk. There's a lot of historic noise, concern, and erroneous beliefs in regards to potential side effects of statins. So in our clinic, we're using a precision approach. We're really trying to stratify risk appropriately. But if somebody is deemed a good candidate for preventative cardiology because they have subclinical disease, we have a big tool belt with a lot of options, a lot of ways to monitor people. And in a lot of our patients, we're able to show plaque regression when they get on a program that appropriately addresses the drivers for this disease process, most of which are pretty well known. So you can identify why your vasculature is showing premature plaque.